who is important for me, for many of us, for her engagement and advocacy she has of the African neurology, the work she is doing to gather people around African neurology. I'm pleased to introduce you Dr. Augustina Charway-Felli, who is elected AFAN president. AFAN is the African Academy of Neurology. She is neurologist at the Military Hospital of Accra in Ghana. Tina, as I used to call her, but many of us call her Tina. Tina, please start when you are ready. Thank you.
Merci beaucoup. It is my honor and pleasure to be with you this evening. So the topic this evening is acute stroke management, and it is a huge topic, one that we can talk for hours about. And I will try to make it as practicable as possible to reflect the realities of where we work and the clientele that we serve. So as with most things, we will start with some definitions so that no matter what we say, we mean the same things. And the definition of a stroke is a sudden onset of focal and or global neurological deficit of vascular origin. Now, this is important, that there has to be no other origin to this sudden onset of neurological deficit but vascular. And as we know, with the brain, the symptoms that we see are based on where in the brain the damage has occurred. So you can have hemiparesis, hemisensory loss, impairment of language, visual loss, ataxia. For global deficit, loss or alteration of consciousness, confusion, and delirium can be signs of a stroke. So if you have any neurological symptom, whether it is global or focal, of sudden onset, and you are able to prove that it is of vascular origin, you are able to make a diagnosis of stroke. So we will repeat the definition of stroke, and we will go on to speak about the definition of a transient ischemic attack, which is also important because for all intents and purposes, it is a stroke just without lasting tissue damage. So the neurological definition of a transient ischemic attack is a brief episode of neurological dysfunction which is caused by focal brain or retinal ischemia with clinical symptoms lasting less than 1 hour, and as I mentioned, without evidence of infarction. So that predisposes that we have to make imaging to prove that there is no evidence of infarction on the imaging. So I will mention a few things that you all know. None of this is news to you. The cerebrovascular risk factors for stroke, ischemic heart disease, prior cerebrovascular disease, atrial fibrillation, hypertension, especially for our population, is one of the most common risk factors for stroke. Obesity, diabetes mellitus, the male sex, and age. I won't spend much time on this. So the symptoms and signs of stroke, as mentioned already, depend on where in the brain the damage has occurred. And we can differentiate between anterior circulation stroke, posterior circulation stroke, and some non-specific signs. So unilateral weakness, unilateral sensory loss or inattention, isolated dysarthria, dysphasia, impairment of vision in the form of homonymous hemianopia, monocular blindness, or visual inattention are usually signs of anterior circulation stroke. And that would be the middle cerebral artery and the anterior cerebral artery. Posterior circulation strokes can give us isolated homonymous hemianopia, diplopia, and disconjugate eyes, nausea and vomiting. So please, when you see someone with sudden onset of nausea and vomiting, do not forget, especially if they fit the demographic characteristics of someone who can have a stroke, do take into consideration that this may be a posterior circulation stroke. Incoordination and unsteadiness, unilateral or bilateral weakness, and or sensory loss. And as mentioned, the non-specific signs are dysphagia, incontinence, or loss of consciousness or impairment of consciousness. So it's important not to forget that whilst it may look like a stroke, it doesn't necessarily have to be a stroke. And so we should be aware of the most common stroke mimics. And these are hypoglycemia or hyperglycemia, seizure, subdural hematoma, infarction or hemorrhage within a mass lesion. So it looks like a stroke. In essence, it is a stroke, but it is a stroke in a mass lesion. Now, the accurate diagnosis of stroke depends on several factors. And first, we need to define the stroke type. Everything else that we do depends on the definition of the stroke type. So once we have defined the stroke type, we will then institute acute general medical care. And then where possible, and some of us do have the luxury of having reperfusion therapies available, and neuroprotection. So with respect to neuroprotection, I will speak very briefly on it along the line, and it is unfortunately very briefly. So again, whilst it is important to remember the stroke mimics, we also have a fairly long list of differential diagnoses for stroke. And that includes symptoms, partial epileptic seizure with thoughts paresis, a migraine attack. Again, it's important to look at the demographics of the individual you're seeing the neurological deficit in. Hypoglycemia, we've mentioned, hysteria, not so common, intoxication. A subarachnoid hemorrhage or a subdural hematoma can also give you acute onset of focal neurological deficit, as can neuroinfections, mass lesion, brain injury, multiple sclerosis, and even peripheral vertigo, especially for the posterior circulation strokes. And the peripheral vertigo can be hard to tell the difference. So it's important that you understand that confirmatory tests are supplementary to and not replacements of a conventional clinical examination. Neurology is still largely clinically based, and all the wonderful methods of investigations we have are supportive. So if you don't know before you go in to do your imaging or have any test done, it is unlikely that that test will give you a diagnosis. So you should base a lot of your decision making on your clinical findings and then add on supporting evidence from your investigations. So very briefly, lacuna strokes are caused by occlusions. This is for ischemic stroke, occlusions of small penetrating blood vessels, and we can have several types: pure motor stroke, pure sensory stroke, ataxia hemiparesis, the clumsy hand dysarthria syndrome. And these, because of the limited nature of the disturbance to the brain tissue, have an excellent prognosis for recovery. Now, we are talking today about the acute management of stroke. So it's important that we see it as a medical emergency. And stroke is the most important cause of morbidity and long-term disability in Europe. And for our region, Sub-Saharan Africa, and other low and middle income countries, it is in fact the largest cause of long-term disability. Demographic changes that we are experiencing are continuing to lead to an increase in both the incidence and prevalence of stroke. It is also the most common cause of dementia and a frequent cause of epilepsy in the elderly, as well as a cause of depression. So it is more than just simply a stroke. The implications of not preventing it, not treating it appropriately, and not doing secondary prevention is quite great. So the emergency care of acute stroke depends on a four-step chain. For many of us, this chain will have breaks in it, but it's important that we understand the nature of this chain so that we can put in place measures to make sure that stroke care can be appropriately given. So it requires the rapid recognition of and reaction to the signs of stroke and symptoms by both the general population, immediate contact of emergency services, and priority emergency services dispatch where this is available. So again, I would understand that in many of our settings, especially outside of our capital cities, this part can be quite problematic. But there should be priority transport with notification of the receiving hospital, again, communication within amongst facilities from the ambulance to the facilities needs to be strengthened. And we need immediate emergency room triage, clinical, laboratory, and imaging evaluation, accurate diagnosis, and administration of the appropriate management where the patient is received. Again, in many of our countries and in many of the hospitals within which we work, there will be challenges with this. However, we need to know what needs to be done, how it should be done, and then institute measures to make sure that in every facility, irrespective of its size, we have a good chain of reaction and availability of the necessary infrastructure in order to provide adequate care. So delays in acute stroke management have been identified at three main different levels. The first one is a population level where the individuals fail to recognize the symptoms of a stroke and contact emergency services. For a lot of our population, it is also lack of access, hope that, oh, maybe let's wait a little bit, it will go on its own before we seek medical care. And that causes a significant delay in management. At the level of our emergency services and emergency physicians, there can be issues with failure to prioritize transport of stroke patients and reception of these stroke patients. At hospital level, due to delays in neuroimaging or simply unavailability of same, again, appropriate specific therapies can be delayed due to this. And again, and this will hold true for many of our facilities, and therefore we need to address these issues: inefficient in-hospital care due to a variety of reasons, most often inadequate staffing and inadequate infrastructure. So I'm sure you've all heard this phrase, time is brain, and the time window for the treatment of patients with acute stroke is very narrow. It is widening with research and advances in medicine, but still it remains a very time tight approach to the management of stroke. Acute emergency management of stroke requires parallel processes operating at different levels of patient management. And the assessment of neurological and vital functions should parallel the treatment of acutely life-threatening conditions. Time, again, it cannot be stressed enough, is the most important factor. Indeed, time is brain. So the initial examination of the individual being received with a probability of a stroke should include the ABCs as with any medical condition. So observation of breathing and pulmonary function, concomitant heart investigations, assessment of blood pressure and heart rate, determination of arterial oxygen saturation. Blood samples should quickly be sent for clinical chemistry, coagulation, and hematology studies. And as soon as possible, observation for signs of dysphagia. So a swallow test needs to be done as soon as it's practicable. If a swallow test is not done, the order to the nurses and especially to the relatives, because in many of our facilities, the relatives remain with the patient, that the patient needs to be left at nil per os until a swallow assessment has been done and dysphagia has been ruled out. You need to do a quick targeted neurological examination, and a careful medical history should be taken, focusing on the risk factors for arteriosclerosis and heart disease. In all patients, brain imaging is mandatory. So at the emergency room level, a CT scan is usually adequate or where possible, and depending on the difficulty in making a diagnosis, an MRI using the stroke protocol for both modalities of imaging. An ECG is important. Laboratory tests should include a complete full blood count and platelet count, prothrombin time or INR, and a PTT. Serum electrolytes, blood glucose needs to be checked. An ESR, sedimentation rate, and a C-reactive protein should be checked, as well as kidney function and liver function. In some patients, depending on the characteristics of the individual, duplex or Doppler ultrasound investigation can be done on the carotids or vertebral arteries. Echocardiography may be required again in a specific subgroup of patients. A chest X-ray should be done for everybody. Pulse oximetry, arterial blood gas analysis, again depends on the state of the patient. Lumbar punctures, EEGs, and toxicology screens should be requested only if indicated by the clinical state of the patient and when the diagnosis of a stroke with a vascular origin is in question. So the main goal of the emergency diagnostic tests is to differentiate between the different types of stroke. Is it an ischemic stroke or is it a hemorrhagic stroke? Because the measures that we need to put in place depend on the type of the stroke that we have identified. It is also required to be able to make an assessment of prognosis so that, again, measures can be put in place to alter that prognosis if possible. And it provides a basis for the physiological monitoring of the patient and identifies concurrent diseases or complications associated with the stroke. And as mentioned, to rule out the differential diagnoses of the neurological deficit. So for computerized tomography, immediate plain CT scan reliably distinguishes between a hemorrhagic and an ischemic stroke. In the emergency room, it is the quickest, it is the cheapest, it is the more readily accessible form of imaging and is usually suitable for most cases. It can detect signs of ischemia as early as 2 hours after the stroke, and especially in the hands of a good radiologist, you can tell the signs. For most of us, determination that there is no hemorrhage is usually enough to then further manage the patient. And as mentioned already, it helps identify other neurological diseases, for example, mass lesions, and is the most cost-effective strategy for acute imaging for stroke. So just a few examples. Again, I'm sure you all know this. When you don't see a defined lesion, look for clues of ischemic changes in the brain. And one of them is the hyperdense middle cerebral artery, which you can see indicated by the red arrow. Here, much clearer, you can see brain swelling, focal cortical effacement, so loss of the differentiation between white and gray matter, and ventricular compression on the side of the lesion. And that is usually a good clue that this lesion that you're looking at is fairly new. If you have the opposite, retraction or widening of the ventricle on the side of the lesion, that often indicates that the lesion, if you're seeing one, is an old one and may not be responsible for the neurological deficits that you're seeing at the current time. So there are lots of different scales and measures that you can use to determine how severe the stroke is in your patient. Here is just one example, and this is the Alberta Stroke Program Early CT Score. The acronym is ASPECTS, and it's a 10-point quantitative topographic CT scan score for patients with stroke in the middle cerebral artery territory, and has also been adapted for posterior circulation. I won't go into the details, but because I will mention it a little bit later, it's important that we remember it. So this is on a CT scan, the differentiation between the different parts of the middle cerebral artery, the anterior cerebral artery, and posterior cerebral artery. And you can see the M1, M2, M3, the M4, M5, M6. And for every part that has a hypodensity or effacement of the gray-white matter, you take away 1 point. And the score you get, again, helps you determine what you should do for your patient. So the two different slices that you saw are taken at this level. A, below the ventricles through the thalamus, and B, at the level near the top of the lateral ventricles. I will show you it again. So we have A through the thalami and B above at the top of the lateral ventricles. All right, so we shall continue now with other emergency diagnostic tests where the CT scan is either not possible or does not provide enough answers, and you still have questions as to whether or not this is a stroke. Magnetic resonance imaging is very useful, and the diffusion weighted MRI, DWI, is more sensitive for detection of early ischemic changes than the CT scan. The DWI, however, can be negative in some patients with definite stroke. So it is not absolute. Again, remember I said your clinical acumen is what you base your diagnosis on, and everything else is merely supportive. The MRI is able to identify ischemic lesions in the posterior fossa reliably, as opposed to the CT scan, where because of the proximity of bone, the tissue of the brain in the posterior fossa is poorly seen, especially that of the brain stem as well. It can also detect even small intercerebral hemorrhages reliably on T2 sequences. The MRI is particularly important in acute stroke patients with unusual presentations. So where your clinical picture is not clear and you want to clarify what exactly is happening with the brain tissue. So when someone comes in with what you have concluded to be a transient ischemic attack, in other words, the neurological deficit that they experienced has already resolved by the time you're seeing them, and it should, because it should resolve within 1 hour. If you're seeing them more than 1 hour after the onset of whatever they say happened to them, and you find neurological deficit on your examination, it's still present, this is not a TIA, it is a stroke. So when it is indeed a TIA and you're seeing your patient and all the neurological deficit has gone away, you should still image them because one, in order for it to be definitely a transient ischemic attack, there needs to be no evidence of infarction on imaging. And here the imaging needs to be an MRI because the CT scan would not be sensitive enough to pick it up. And it's important that these patients be imaged because there's a 10% recurrence risk in the first 48 hours after the onset of the TIA of a full-blown stroke. So it's important, again, to be able to put measures in place in order to prevent as much as is possible a stroke from occurring. The simple scoring systems can be used to identify patients at particularly high risk. So again, aside from the imaging, they need a full cardiovascular workup to again determine their stroke risk. For example, atrial fibrillation. 50% of patients with transient ischemic attacks already have acute ischemic lesions on DWI. And these patients, again, are at an increased risk of early recurrent disabling stroke. However, there is no evidence that the imaging alone, the DWI, provides better stroke prediction than clinical risk scores. So again, I will repeat this, your clinical evaluation is most important in determining what to do for your patient. So every patient who has suffered a stroke needs an electrocardiogram, and it is common to find cardiac abnormalities in stroke patients. Arrhythmias may induce stroke, but the converse is also true that the stroke may induce an arrhythmia. Holter monitoring is superior to a routine ECG, although a routine ECG in the emergency room must be done for the detection of atrial fibrillation, because it is a very common cause for cardiogenic stroke, cardioembolic stroke. It is unclear whether continuous ECG recording at the bedside is equivalent or superior to Holter monitoring for the determination of atrial fibrillation. So as we mentioned, other laboratory tests depend on the particularities of the patient that you're seeing. Now, a very important issue where many of us fail to manage our patients correctly is with respect to blood pressure management. The general consensus is, and I will give you a few slides coming in a few slides, the consensus statement from experts of the European Stroke Organization. And they do echo many of the studies and the consensus statements and guidelines from many of our leading stroke organizations. So the first thing is, do not treat high blood pressure in acute ischemic stroke unless it is over 220 for systolic and 120 for diastolic, or the patient is, at the time of being seen, having a myocardial infarction, there is evidence of aortic dissection or acute glomerulonephritis, or this patient is a candidate for thrombolysis and thrombolysis is available. So for this, the blood pressure needs to be less than 180 over 100. The other rule is stop all home blood pressure medications. You have to ask your patient, or if they are not able to speak, the accompanying people that come with the patient, if their blood pressure medications have been taken that day, if they are hypertensive or they know themselves to be hypertensive. So these following slides will be from the consensus statement from the European Stroke Organization, and it has been found that pre-hospital management of blood pressure in acute stroke is not beneficial. I will not speak for other countries outside of Ghana, but I do know that it is fairly common practice. The first place of call where the patient who is experiencing a stroke goes to often finds on examination that their blood pressure is high, and they're very often given a blood pressure reducing agent. This is incorrect practice. In hemorrhagic stroke, glyceryl trinitrate needs to be avoided. So those patients who are not treated with reperfusion therapies, and this will be most of our patients, the use of routine blood pressure lowering agents should be avoided in the first 24 hours, unless it is indicated for a specific comorbid condition. And I mentioned those in the previous slide, that is a myocardial infarction, acute glomerulonephritis, an aortic dissection, or some other conditions. But if none of those are present and the only problem is the stroke, acute and routine blood pressure lowering agents should not be used. And this is because the pathophysiology of, or rather the homeostasis of blood pressure within the cranium is slightly different from what we are measuring, which is the blood pressure peripherally. And often after a stroke, within the first 24 hours, the blood pressure without any external agents does go down, and you don't want it to go down too far. In patients with large vessel occlusion undergoing mechanical thrombectomy with or without thrombolysis, we need to keep the blood pressure lower than 185 over 110 diastolic. So this is the main difference between those who get reperfusion therapies, whether it's thrombolysis or thrombectomies, and those who don't, the threshold of the blood pressure. So in-hospital management of hypertension in patients with acute ischemic stroke that are not treated with reperfusion therapies, we've mentioned that end with clinical deterioration where a hemodynamic mechanism is suspected or shown to be directly responsible for the deterioration, the consensus guidelines state that they suggest stopping existing blood pressure lowering therapy, administration of intravenous fluids, and introducing non-pharmacological procedures to raise blood pressure. So that is when our patients go into acute shock from whatever reason. And this should be done before the use of vasopressor agents to increase the blood pressure with close monitoring of the blood pressure values. So they go on to say the European Stroke Association expert consensus guidelines that in patients with acute ischemic stroke, we suggest stopping previous oral blood pressure lowering therapy, we've mentioned this already, in patients with dysphagia until swallowing is restored or a nasogastric tube is in place. So generally, in the emergency room, as mentioned before, the first rule is until a swallow assessment has been done, the patient needs to be kept nil per os, and this can be kept in the first 24 hours. Ultimately, without food, the patient will not be harmed, and fluids can be replaced easily using intravenous access. And this is also based on studies, the Cossacks and the ENOS, which showed a odds ratio of worsening of prognosis with the institution of home blood pressure, previous oral blood pressure reducing agents. So we know that the advances in the treatment of acute ischemic stroke have been taking strides over the past decade. Unfortunately, the same cannot be said about intracranial hemorrhages. With respect to blood pressure of acute hemorrhagic stroke, the following consensus guidelines sound this way. So in patients with acute, less than 24 hours intracerebral hemorrhage, there is continued uncertainty over the benefits and risks. So there has always been a discussion about how quickly does blood pressure need to be reduced in intracerebral hemorrhage. And there have been trials where rapid, intensive blood pressure lowering as opposed to conservative blood pressure lowering has been tried, and it remains unknown which is more beneficial. In fact, they're probably about the same in terms of risk of lowering on functional outcome after the stroke. In patients, however, with hyperacute, so you're seeing them less than 6 hours after symptom onset, the guidelines suggest lowering blood pressure to below 140 and to keep it above 110 millimeters mercury for systolic. So as we know, there is a U-shaped curve between the blood pressure and mortality. The lower the blood pressure, below 110, the higher the mortality, the worse the prognosis, and of course, above 160, again, there is a U-shaped relationship between the blood pressure and the prognosis and mortality. So within the hyperacute state, the blood pressure reduction, the goal of it is to reduce hematoma expansion, to stop the blood from continuing to spill. In patients with acute intracerebral hemorrhage, the guidelines continue to speak. They suggest initiating antihypertensive treatment as soon as possible, ideally within 2 hours of symptom onset. So that requires, again, we spoke about the delays in management. That requires that the individual gets to the hospital within 2 hours of symptom onset, which in the best of settings is quite difficult, but especially in ours. The decrease of systolic blood pressure should not exceed 90 millimeters mercury from baseline values. So again, there is still a limit to how low you should bring the blood pressure and how quickly. In patients with acute intracerebral hemorrhage, they continue to say that they suggest lowering blood pressure according to recommended levels beyond 6 hours after onset of treatment for at least 24 hours and up to 72 hours to reduce hematoma expansion. And the studies that it was based on showed that blood pressure lowering with any vasopressor compared to vasodepressor, pardon me, compared to control in intracerebral hemorrhage on good functional outcome, does show some benefit in reducing blood pressure hyperacutely. So here is a relatively simple breakdown. Let's say you have diagnosed a stroke, acute stroke. You determine whether it's ischemic or hemorrhagic. When it's hemorrhagic, depending on the blood pressure levels and when you are seeing the patient from symptom onset, there is a series of things that need to be done. With ischemic, is there going to be reperfusion therapy or not reperfusion therapy, and what needs to be done? I assume the organizers of the seminar will materials to the audience. So now we will move on slightly to specific stroke therapies. So again, I know most of us will not have the luxury of being able to do this. However, in many of our capital cities, with the progress in our provision of healthcare, some centers are able to do this. And it's still important to know so that should this become available, you already know what needs to be done. So the specific stroke treatment, and this we're going to be speaking now only about acute ischemic stroke because that's the only one that has specific treatments. There is thrombolytic therapy, early antithrombotic treatment, treatment of elevated intracranial pressure where this is present, and prevention and management of complications. So again, we will talk about the blood pressure for these patients because whether or not they are eligible for thrombolysis depends also on their blood pressure. So earlier thrombolytic treatment in patients with acute ischemic stroke is not only associated with more and frequent independent ambulation at discharge and discharge to home, but is also associated with a reduced mortality and reduced symptomatic intracerebral hemorrhage. The elevated blood pressure can affect the thrombolytic eligibility, and that's why we're talking about it again, and has been associated with delay in administration of IV tissue plasminogen activator. So we have available alteplase and tenecteplase. Both have been indicated for the use in thrombolysis. So one factor that has been associated with delays in treatment times, again, is the need for pre-thrombotic blood pressure to be less than 185 over 110 millimeters of mercury, and this target has been extrapolated from prior studies of thrombolysis in acute myocardial infarction. So another method of reperfusion is thrombolysis with intra-arterial thrombectomies. Prior to the procedure with IV TPA, the blood pressure needs to be 180, less than 180 over 105 millimeters mercury. If there is only going to be intra-arterial thrombectomies, the blood pressure can be reduced by 10 to 20% of the admission blood pressure, and that is considered a reasonable goal if recanalization is possible only with the intra-arterial thrombectomy. During the procedure, extreme caution needs to be taken to avoid relative hypotension during the procedure, as general anesthesia can also cause a drop in blood pressure. In addition, the systolic blood pressure needs to be maintained at about 140 millimeters mercury so as not to worsen the penumbra and the collateral circulation of the patient. And it has been shown that a blood pressure of less than 140 is a predictor, an independent predictor of poor neurological outcomes after the endovascular treatment. So after the procedure has been done, if you have been fortunate enough to get it done, the blood pressure can be titrated according to the degree of recanalization that has been achieved. And it needs to also be based on the patient's neurological examination. If based on the angiogram, recanalization, complete recanalization has been achieved, then the blood pressure can be reduced to a systolic blood pressure of between 120 to 140 millimeters mercury to lower the risk of reperfusion hemorrhage. If, however, there's only partial recanalization, it is reasonable to maintain the systolic blood pressure to around 180, not more than 185 millimeters mercury for the next 24 to 48 hours. And this is in order to be able to augment, to have extra collateral blood flow and clear the emboli from the distal vasculature, unless the patient has prior received intravenous thrombolysis. The blood pressure must ultimately be optimized to minimize the risk of symptomatic intracranial hemorrhage and reperfusion and injury, and to promote adequate cerebral perfusion. So it's always a balancing act. You want the blood pressure to go down, you don't want it to go down too far, and it is important that we do not at this point use oral medication, because onset of action, duration of action is extremely difficult to predict with oral medications. And so intravenous parenteral agents at this point are what needs to be used. So a little bit about the history of thrombolytic therapy, the background based on the NINES, the ECAS, and the Atlantis trials. Intravenous recombinant tissue plasminogen activator at a dose of 0.9 milligrams per kilogram body weight, with a maximum dose at a time of 90 milligrams, are given within 3 hours of stroke onset. So with the latest guidelines for the management of stroke, this window has been increased from 3 hours to 4.5 hours. There are some nuances as to whom we can still include, but in the guidelines, up to 4.5 hours from onset of symptoms, thrombolysis can be given. Benefit from the use of IV RTPA beyond 3 hours is smaller, as mentioned, but can still be present, and therefore that's why the guidelines have been changed, can be present up to 4.5 hours. There are, however, several contraindications, and I will mention them in a little bit. So there are some issues, and these are mostly related to factors associated with increased bleeding risk. And this is an elevated serum glucose. So someone who is diabetic has a poorer likelihood of improvement from thrombolysis, the history of diabetes, as mentioned, baseline symptom severity, and advanced age. Although this is not a contraindication, it is a caution. Increased time to treatment, and that's why it's important that we stick to the timelines. Previous aspirin use makes, again, it complicated and is associated with increased risk of bleeding, a history of congestive heart failure, and violations of protocols. So again, it's very important for those of us who, again, have the luxury to have these methods of treatment available. We need to have strict guidelines, strict protocols, and when we follow the protocols closely, we are more likely to be successful. It's important also to note that despite all these potential problems, none of these have reversed the overall benefit of the thrombolysis. So the following are eligibility criteria for reperfusion therapy. So the diagnosis of ischemic stroke causing a measurable neurological deficit. So if there is no deficit, there is no need for it. Neurological signs have not cleared spontaneously. Again, so if it's a TIA, they do not qualify for a reperfusion therapy. The neurological signs are not minor and isolated. The symptoms are not suggestive of a subarachnoid hemorrhage. So here you have by all means done imaging and proven that this is an ischemic stroke. The onset of symptoms have to be less than 3 hours from beginning of treatment. And like I mentioned, there are a few caveats where it can be extended to 4.5 hours. And the following are extremely important. There should be no head trauma or prior stroke in the last 3 months, because these significantly increase the risk of hemorrhage. There has been no myocardial infarction in the prior 3 months. There has been no gastrointestinal or genitourinary hemorrhage in the last 21 days. There has been no arterial puncture in a non-compressible site during the prior 7 days, no major surgery in prior 14 days. And unfortunately, this then means that many of our post-anesthesia stroke So when they recover from the anesthesia, they realize they've had a stroke, are not eligible for reperfusion therapy. And there has been no history of prior intracranial bleed. So much of the evidence of the benefit of intraarterial thrombolysis comes from the PROACT trial, and it used pro-urokinase. It extended the use of reperfusion therapy to 6 hours, and it found a relative risk reduction of 15% in functional outcome, with no significant difference in mortality. There are, however, procedural complications in 9%, and early intracerebral hemorrhage can occur in 10% of patients. So again, to recap, the eligibility criteria for the thrombolysis: your systolic blood pressure needs to be under 185 millimeters mercury, and the diastolic less than 110. There should be no evidence of acute trauma or bleeding. The individual needs not to be on an oral anticoagulant, and if they are, so they have a preceding illness that required that they were on an anticoagulant, the INR when checked should be 1.7. Again, this brings into focus the extreme need of getting these methods of investigations very early, get them done early, and get the results early so that they can be used in determining the eligibility of the individuals for reperfusion therapies. If they have been on heparin within the last 48 hours, they should have a normal activated prothrombin time. They need to not have thrombocytopenia, so the platelet count needs to be more than 100. The blood glucose needs to be greater than 2.7 millimoles per liter, and they shouldn't have had a seizure with residual post-ictal impairments. And the CT scan should not show evidence of multilobar infarction with the hyperdensity covering over a third of the hemisphere. It is important to counsel both patient and the relatives, and they need to understand both the risks, because they are there, and the benefits of therapy. So this should be a procedure that is done with consent. So we have mentioned already the thrombolysis exclusion criteria. For those who present or who are now at 3 to 4.5 hours after the stroke onset, they need to have not more than one of the additional exclusion criteria. So for patients older than 80 years, if they're less than 3 hours from onset, they are eligible. After 3 hours, they are no longer eligible. All patients that are taking oral anticoagulants are excluded, regardless of the international normalized ratio, the INR. So if below 3 hours, if you come before 3 hours and the perfusion therapy is going to be done before 3 hours and your INR is less than 1.7, you qualify. After 3 hours, between 3 to 4.5 hours, no matter what your INR, you do not qualify for the reperfusion therapy. If you have a history of stroke and diabetes, and those with imaging evidence of damage to more than 1/3 of the middle cerebral artery. So this is for exclusion criteria for those who are undergoing the procedure after 3 hours and before 4.5 hours after onset of neurological deficit. So the eligibility criteria for thrombectomies are slightly different. The time from onset, depending on the vasculature. So for anterior circulation ischemic stroke, thrombectomy is indicated up to 16 hours from symptom onset. So theoretically, a lot more of our patients will qualify for thrombectomies than thrombolysis, especially taking into consideration the delays in getting the investigations, getting blood pressures, etc. And this includes wake-up stroke, and is indicated in select patients up to 24 hours from the last time they were known to be normal. And this replaces the 2015 guidelines where thrombectomy recommendations were limited to the first 6 hours. So in certain cases, and again, this is in certain cases and needs to be per the protocols of your facility, you can extend the eligibility up to 24 hours after stroke onset. So for the imaging, in patients with anterior circulation stroke within the first 6 hours or an aspect score more than or equal to 6, and a MRI DWI aspect of more than 6, good to moderate collateral status on CT angiography, and with more than 50% of the MCF territory and small lesions, they qualify. In patients with anterior circulation stroke due to intracranial internal carotid artery or M1 occlusion within 6 to 24 hours symptom onset, who meet the criteria of MRI or CT perfusion studies. So the thrombectomy can also be indicated in carefully selected patients who do not meet the criteria for the dawn, and so the wake up, stroke, and diffuse 3, but otherwise have favorable imaging profiles, such as the CT aspect of 6 to 10, the MRI DWI aspect of 6 to 10, moderate to good collateral status on the CT angiography, and a small core impact on advanced MRI and DWI studies. So this, again, in order for us to make this available to our patients, we need to have the necessary infrastructure in place. In general, for all the reperfusion therapies, the thrombolytic therapy is the least infrastructure intensive. All you need is the medication and a drip stand, and of course training for those who would apply it, but that doesn't require much. For thrombectomies, more patients can be treated. However, this is dependent on training, significant training of the interventional neurologist, the interventional radiologist, or sometimes it's an interventional cardiologist who does it, and requires a backup of a significant amount of infrastructure. So the imaging, the CT scan, the different types of imaging protocols, and the different MRI protocols, angiography, etc. Apologies, there are some duplications in the slides. Okay, so depending on the stroke severity, thrombectomy is indicated in patients with anterior circulation with an NHIS score of greater than 6, and can be considered in patients with anterior circulation and an NHISS score of less than 6 when associated with disabling symptoms. However, care should be taken when treating these patients to keep complications and hemorrhagic rates below those reported in randomized controlled trials. So this would depend greatly on the facility, the skill of the interventional specialist, etc. So age of above 80 should not be used as a contraindication. So the indication needs to be based on stroke type, stroke location, the blood vessel involved. And the benefit of thrombectomy in patients with a baseline MRS of greater than 1 is not known. So it is better not to use these patients. So this is where most of our patients will actually fall, and that is when thrombolysis or thrombectomy is not an option, either in terms of time or infrastructure, availability of both the thrombolytic agents or the skill of, or the presence of someone skilled to do thrombectomies. And in general, when these are available, the thrombolysis and thrombectomy are still not an option where there is uncertainty surrounding the optimal management of blood pressure. And you need to take into consideration the potential of compromising collateral blood flow and hastening the interval to infarction. It is best to observe current guidelines. So we often, especially because this is a relatively novel method of therapy for our region, these guidelines, we need to use other guidelines from different regions. And as time goes on, as we build up our experiences, build our own guidelines that are appropriate to our patients and to our level of assessment. So this is what actually most of us will be doing, and that is general stroke treatment, irrespective of the type. One, if imaging has not been possible, and where specific therapies are not available. So with every medical condition, you are taking care of the ABCs: airway, breathing, circulation. You're monitoring fluid balance, you're monitoring blood pressure, glucose metabolism, and temperature. And from these come the potential complications and the measures that need to be put in place so that these complications do not occur. So the recommendations for general stroke treatment, irrespective of type, sound as follows. Intermittent monitoring of neurological status, pulse, blood pressure, temperature, and oxygen saturation is recommended for at least 72 hours in patients with significant persisting neurological deficits. Oxygen needs to be administered if the partial saturation falls below 95%. And regular monitoring of fluid balance and electrolytes is recommended in patients with severe stroke and swallowing problems. For evidence of elevated intracranial pressure, the basic management includes elevation of the head up to 30, sometimes 60 degrees, pain relief and sedation, the use of osmotic agents. Glycerol, mannitol is the most commonly used. Hypertonic saline should be avoided, but can be used in the absence of anything else. Ventilatory support, the use of barbiturates, hyperventilation, and normothermia is important, as we know that hypothermia may reduce mortality. If there is a malignant middle cerebral artery hemispheric infarction where there is significant increase of pressure, signs of herniation, analysis shows that decompression surgery may be beneficial, and it's important for the family, because usually the patient is in no condition to give consent or understand what is happening. The family needs to understand that these procedures are not deficit reducing, these are life preserving procedures. After 48 hours, doing a decompressive surgery is of no value, and the site of infarction appears to affect the outcome. The older the patient, the poorer the prognosis. So the acute management of intracerebral hemorrhage, we've already mentioned this. Acute treatment itself, there is very little in terms of change over the last 50 years for the guidelines. And basically, the management boils around prevention of complications and the management of high blood pressure. So I mentioned earlier that we speak about neuroprotection. In theory, neuroprotection, the agents that are supposed to boost the recovery potential of cerebral tissue, in theory is fantastic. Unfortunately, no real life world study has shown any real benefit from any of the neuroprotective agents that are available at current time. And so, with consideration of pill burden, consideration of side effects, consideration of expectations, we should use these agents extraordinarily carefully, is how I will put it. We are often put in a position where it appears as if we're not doing anything, but doing something just for doing sake can often be harmful to the patient. And we need to explain it that way to the patient and the family when they feel that, oh, we're not giving them high blood pressure medication. Oh, I've heard of this amazing medicine. It says brain booster. on it, why aren't we using it, you have to explain the real medicine behind why we use or do not use certain agents. So as the person gets further away from the acute onset of the neurological deficit, the main things we need to take care of are the blood pressure. The hypertensives to be used should include an ACE inhibitor or an angiotensin receptor blocker. Other hypertensives, depending on the blood pressure requirements. For those who have diabetes mellitus, they need optimal glycemic control. So in the acute phase, insulin is the way to manage the glycemic control. As they get further away into the subacute and chronic phase, they can then be returned to oral medications if their glycemic control is satisfactory on oral medications. All patients with acute ischemic stroke, irrespective of cholesterol levels, need to be put on a high potency statin. We do still need to bear in mind the levels of the cholesterol, but whether or not the levels are supposedly normal depends on what is wrong with the patient. And everyone with an acute ischemic stroke, especially those who get their stroke in older age, do need to be on a statin unless there are specific contraindications to the statin, for example, significant liver failure, etc. Now, vitamins have been considered to be neuroprotective and therapeutic. Unfortunately, we still have not enough evidence to support their use, and depending on the agents that are being used, and we have to remember that our patients often are on several different supplements, they can be harmful. Antithrombotic therapy, anticoagulation depends on whether or not they have an ischemic stroke, and anticoagulation depends on the cardiac comorbidities that they have. Now, measures need to be put in place to prevent complications, but where they have still occurred despite preventative measures, the most common complications are aspiration and pneumonia, and is the most significant complication in stroke and can significantly alter prognosis. The preventative strategies are, as mentioned earlier, to withhold oral feeding until demonstration of intact swallowing, preferably using a standardized test. And if swallowing is not intact, to use a nasogastric or a percutaneous enteral gastrostomy tube, and frequent changes in position of the bed and pulmonary physical therapy. It is also really important to start teaching the family how to use the nasogastric tube if it is present. And even some of our nursing staff needs to be cautioned and not to assume that just because a nasogastric tube is in place, that aspiration becomes impossible. Feeding needs to be done in the correct position with the patient seated nearly upright. Prophylactic administration of any antibiotic, and levofloxacin in particular, is not considered necessary and is not superior to optimal care. Antibiotics should be used when indicated and not as prophylaxis. So urinary tract infections are also fairly common in those who are hospitalized, especially those who end up being catheterized. And it is usually because of the catheter that they develop the urinary tract infections. Intermittent catheterization does not reduce the risk of infection. And if an infection is diagnosed, the appropriate antibiotic needs to be chosen following basic medical principles. So you start with empiric therapy, broad spectrum antibiotic, get a culture and sensitivity, and then target your antibiotic treatment based on the sensitivity panel. The prophylaxis of deep vein thrombosis and pulmonary embolism can be reduced by adequate hydration and early mobilization and the use of low molecular weight heparin. So for those who have suffered a hemorrhagic stroke, The low molecular weight heparin is not contraindicated after 48 hours from the hemorrhage on condition that the patient is not deteriorating and repeat imaging does not show signs of hematoma expansion. Again, this warrants that blood pressure has been adequately controlled because the increased high blood pressure adds to the risk of hemorrhagic complications. So the other complications we need to be concerned about are the development of pressure ulcers and the use of support surfaces, frequent repositioning, optimal nutritional status, and moisturizing sacral skin can be used as preventative strategies. Seizures, if they do occur, need treating. If there are no seizures, prophylactic use of anti-seizure medications is not indicated. If the patients do develop seizures, especially for the majority of elderly patients with comorbidities, the drug of choice is sodium valproate and not carbamazepine, as carbamazepine can be arrhythmogenic. If the patient is agitated, and they often are, we need to identify the cause of the agitation. They are uncomfortable, they are in pain, they can't breathe properly, and address those before the use of any kind of sedation. And if you have to use sedation, quetiapine is your drug of choice, and you start with the smallest possible doses. Use as little as possible. The use of restraints is only a last resort. For dysphagia and feeding, we've spoken about this. Dysphagia occurs in about 50% of patients with unilateral hemiplegic stroke, and unfortunately is an independent risk factor for a poor outcome, also because of the complications that arise from it. For those with continuing dysphagia, options for enteral nutrition include the nasogastric tube or PEG feeding. And there is no real superiority of PEG over the nasogastric tube except in its ease of use. It is wider and it is easier for home care. Now, rehabilitation is extremely important, and it shouldn't be left as an afterthought after the person has been discharged. Early rehabilitation starts within the first 48 hours from the stroke. The majority of patients, 40% of them, will require active rehabilitation, and it should be started early, providing the patient is clinically stable. For those who are not clinically stable, passive or modified rehabilitation can still be started, but it needs to be done with consideration of the comorbidities. Rehabilitation needs to take place as long as perceptible recovery is taking place. So when we are discharging our patients, we counsel them and say that whilst most of the recovery of function will take place within the first 4 weeks from the stroke, the recovery can continue up to a year after the stroke, and therefore rehabilitation needs to continue as long. And even after that, rehabilitation in terms of physiotherapy now takes the place not only of improvement of function, but for prevention of complications of reduced mobility. It is very important in the management of stroke from the very beginning to consider it as a multidisciplinary problem. The stroke team needs to include a stroke physician, nurses experienced in stroke management, the physiotherapist trained in stroke rehabilitation, an occupational therapist, the speech therapist, neuropsychologist, the cardiologist, and other specialists of internal medicine are often necessary in order to provide the patient who has suffered a stroke with optimum care. And a social worker is usually helpful for those who have been discharged home to make sure that the home is prepared for the individual and the deficits that they still have, and that they continue with their rehabilitation. Now, one thing we often fail with, but it's extremely important, is documentation. So right from the very first moment that you set your eyes on your patient, you need to accurately document the Glasgow coma state of the patient, the neurological deficit. You can use whatever scale is appropriate for your facility. Common one that is used is the NHISS score. You need to document all their premorbid conditions. For example, they are hypertensive, they're diabetic, they're on medications, they have other issues or medications they are on. Were they compliant with their medications? As you monitor your patient, the blood pressure, the sugar, the temperature on admission, and the trend, the ECG findings, whether or not they were on specific medications such as anticoagulants or antithrombotic agents before admission, and monitoring the functional status, for example, using the Barthel ADL scale, and post stroke on discharge, the modified Rankin Disability Score. That way, when we see our patients for review, we're able to assess progress or lack thereof so that we know what other measures need to be put in place in order to provide them the best possible care. So, to conclude, there is good evidence for general medical care in acute stroke, acute aspirin treatment for ischemic stroke. Where possible, thrombolytic therapy needs to be given within the first 4.5 hours from onset. Thrombectomies can be done up to 12 hours generally, and in certain cases can be extended up to 24 hours. There needs to be acute and chronic rehabilitation on a specialist stroke unit. So we know that when patients are taken care of in dedicated facilities dedicated to stroke and the management of stroke, the outcomes are much better than if they are taken care of on a general ward. Secondary stroke prevention begins in the acute phase with high-dose potent statins, the appropriate management of hypertension, the appropriate management of other comorbidities such as diabetes, and lifestyle changes. And again, I will stress adequate rehabilitation. A lot of the work we do will come to nothing if the rehabilitation is not done appropriately. And with that, I thank you very much for your attention. I am happy to take any questions and I will do my best to answer them as best I can. Michel-Arnaud, we can't hear you. I can't hear you.
Michel-Arnaud, you must activate your microphone, please. Active your microphone.
Michel-Arnaud, we still can't hear you.
Michel-Arnaud, please active your microphone. Michel-Arnaud, you must active your microphone. Please active your microphone, Michel-Arnaud.
I think he's having difficulty doing that.
Allô, oui. Oui, mais on ne te reçoit pas ici, hein?
Oui, je me reconnais. Can you hear me? No.
Yes, Michelle.
Yes, sorry. I don't know what happened. My mic was on.
Technology.
Yeah. Okay. Yeah, thank you, Tina. Thank you for the question you put on your presentation, and sorry for the inconvenience I had. No question on the chat. We still have people connected. Il y a certainement des auditeurs en français, donc vous pouvez poser vos questions en français. On les traduira, mais Dr Tina est parfaitement bilingue. So I was just saying to French-speaking people to feel free to ask their question in French, and then we could translate.
Oui, j'ai compris.
Yes.
Merci.
As there is no question, I have one question, Tina, about the superiority of nasogastric tube and gastrostomy, parenteral gastrostomy. You say there is no superiority in terms of nutritional feeding, in terms of feeding people. But in terms of security, there is definitely, for me, I guess, a superiority of gastrostomy compared to nasogastric tube.
Yes, absolutely. So when we look at what can be put through either tube, whether it's nasogastric or the PEG, there is no difference in terms of nutrition. But it is absolutely safer, especially for home care with the gastrostomy tube. And it is actually in diameter a little bit bigger than the nasogastric tube. So when we go home, when the patients go home, and unfortunately, many of our patients will not be able to use the specialized feeding preparations that exist. So it will be our local foods that are pureed and ground that will be put in the NG tube, and the PEG is able to sustain that a little bit better than the nasogastric tube. But that is the main benefit. So if it looks after 2 weeks that it is not likely that the individual will regain their swallowing ability, we recommend at 2 weeks for the nasogastric tube to be changed into the gastrostomy tube.
So you mean in Ghana you use PEG for patients, but because
Yes.
in Libreville not yet here, we are still reluctant to use PEG.
We definitely recommend it. The problem is that the device that needs to be put in is expensive, so many patients cannot afford it. And when they can't, then they are left with a nasogastric tube. But it's definitely recommended. Whether or not we use it frequently is a completely different conversation.
Yeah. Okay. Merci, Tina. I have a call from Sumaila. Let me just pick it. I don't know if it's still. Yeah, maybe it was a mistake from him. We still have people online. Any question?
So I think many will have this kind of question. So we get disappointed when we think that we don't have thrombolytic therapy available. We don't have thrombectomies available. The reality is, even in Europe, even in the Americas, where these things are readily available, the majority of patients with acute ischemic stroke are still not eligible for these therapies. And irrespective of the availability of these therapies, it is general care that determines the outcome of our patients. So if we get the general care done well, our patients will still fare okay. So we shouldn't just give up and say, oh, well, we don't have thrombectomy, we don't have thrombolysis, our hands are tied. Because it is ultimately, and I say this for most of neurology actually, in the end, it does matter what diagnosis you make, but the big fancy name of the diagnosis that you make doesn't matter if basic nursing care and general medical care fails. So we need to beef up those systems first, and then when we are able to have available the thrombolytic therapy, the thrombectomies, etc. Because even if you've done a thrombectomy, but the basic general care fails, it is a wasted effort. So we all need to put effort into first beefing up the basic medical care of our patients and then work on getting the other more advanced therapies available.
Yeah, right. Even here in Libreville, we have a neurovascular unit since 3 months now. Since, let's say, end October 2021. And yeah, people are still coming late, so they are not eligible for thrombolysis. We are still looking for our first patient.
Yes.
Yeah.
Absolutely. And they get very disappointed because they think, so here in Ghana, there is one facility that does the both thrombolytic therapy and thrombectomy. Thrombolytic therapy theoretically can be done anywhere. All you need is the agent. But because it's so expensive, so I see in the chat someone is asking the question about cost of thrombolytic therapy in Ghana. The alteplase, we use alteplase sometimes, but not often. We have tenecteplase, and it costs one vial, so that's 50 milligrams in a vial, ends up costing around, if I translate it into dollars so that we all understand, it should be around $1,000. And that is not readily available for most of our patients. So that and the fact that it's a private facility that does the procedure, which means there are added costs. The hospital stay, everything else is more than it would be if it was in a public general hospital. So it is beyond the reach of the majority of patients. And again, because of that, it is important that we still stress the importance of the general medical care.
Thank you, Tina. Here in Gabon is $2,000 about, but that includes even the stay in hospital and over medication. But the good part of the treatment is that this $2,000 is covered at 80% by the national insurance.
Oh, that's fantastic.
Yeah, for most of the
unfortunately,
people.
in Ghana, the national health insurance does not cover it. I suppose some people will have private insurance, private health insurance, and that may cover it. But again, the majority of people would, if they're lucky, have only the national health insurance, and that does not cover the reperfusion therapies, and especially not in a private facility.
Yeah. We have a question from Delphine. Delphine from Rwanda. Do we have to give all stroke victims the statin irrespective of their cholesterol levels?
So for ischemic stroke, yes, with a caveat. If the LDL, so the LDL component of the cholesterol, the target is less than 1.8, between 1.6 and 1.8. If it is less than 1.3, 1.2, because of the association between extremely low cholesterol levels and hemorrhagic complications, the statin needs to be stopped. The truth of the matter is, no, it's not every patient. It is most patients, especially the elderly patients, and then those whose cholesterol levels are above 1.8. And so if it's a young patient, for example, who has had a stroke from sickle cell disease, for example, the role of atherosclerosis does not exist here, so the statin would be useless. Even antithrombotic therapy for stroke in children from sickle cell disease is not indicated. So the simple answer is yes, everybody, but if we break it down to the subpopulations of people with stroke, not every single person who has had a stroke requires the statins. It needs to be, like most therapies, it needs to be done on an individualized basis. There is the guideline, and based on the characteristics of your individual patient, you target your treatment accordingly.
Yeah, thank you, Tina. I hope that's clear for you, Delphine. Okay, we have some, yeah, we still have some 4 people online. Apparently, we cover all the questions. I don't know if there is no one else who wants to ask questions. I will ask you, for sure, you had a summary at the end of your speech. Do you have a final word for us, Tina? Now, a final word as a fan president. I know you, we all know you as a fan president first. So, do you have a word for us for those 4 people who are online? Yeah.
Well, thank you for staying till the end. Um, if you are all neurologists, I am very glad. The African Academy of Neurology is its main goal is to get the numbers of neurologists on the continent working on the continent. So not just Africans working somewhere else, but Africans working on the continent to higher levels. And this is mostly, in fact, this is only so that our population, our African population, irrespective of the fact that we're African, irrespective of whether we live in a village or we live in the capital city, we can get access to appropriate care. So we do this in a variety of ways, and it's mostly through training, training of neurologists on the continent, and with collaboration with some of our international partners, exchange programs outside of the continent, but mostly on the continent. And through a variety of training programs, like this one, for example, you don't have to be a neurologist to listen to the management of stroke. We have other programs, again, done in collaboration with our international partners on movement disorders, on headache, both to interest those who are not neurologists in neurology, because it's such an important part of the human body, the nervous system, and there's virtually nothing that happens in the nervous system without the involvement of the there's nothing that happens in the body without the involvement of the nervous system. And we all know that now we are moving towards the theme of brain health, without which other kinds of health cannot be spoken about. So we want to interest other medical personnel in neurology, if not to become neurologists, but at least to increase the awareness of neurological disease. And again, the goal of that is so that anyone living with a neurological disease, irrespective of where they are, whether they have access to a neurologist or not, at least will have someone to recognize their problem and to start managing it correctly.
Yeah. Thank you, Tina. Thank you very much. Thank you all for being there that late.
Okay, thank
Thank
you.
you also to the Repremaf community team and Sumaila, who is representing all the team. It's also
Thank you very
always
much, Tina.
a pleasure to share about neurology, share with people that know a lot, like Tina. Thank you for the last people in the audience, Delphine, Maoli, Kamara, and someone called Yes. So thank you, all of you guys,
Merci beaucoup.
and hope to see you
Thank
next
you.
at the next webinar.
Tina,
Yeah.
the presentation was very clear. We don't have
Merci beaucoup.
many questions. Thank you.
Bon.
See you next time
Okay.
for other
Cheers.
webinar on
And
neurology topic.
yeah, happy end of Ramadan for all the Muslim people.
Okay, thank you.
Yes, have a good Eid.
Yeah.
Okay. Thank you.